Hello everyone and welcome to our peripheral symposium of essential large bore access and complication course. My name is Tiago Nalajco and I'm a cardiac surgeon, an interventional-like cardiac surgeon. Today I'll be joined by Dr. João Brito, interventional cardiologist, Dr. Henrique Mesquita Gabriel, interventional cardiologist, and also Dr. Pedro Gonçalves, interventional cardiologist. For those of you who only join us today, it's important for you to understand that in the app you can have the three buttons on the top. You'll have the televote, you'll have the chat, and you'll have the questions to the moderator, so you can click and send us your information, your insights, and also a quick pledge for you to go to our exhibition hall and check our sponsors, of whom we thank at the beginning. And as so, before beginning with our course, I'm going to start already with one question we'd like to pose for you to vote there at home, and therefore introduce our symposium. We're going to have two parts. We're going to talk to you first about some technique issues, and then we'll show you some cases. And therefore, we're going to start with this question that will appear on your screens in a few moments. So the question is, my most commonly used technique to gain femoral access is A, exclusively ultrasound guided, B, ultrasound plus fluoro, C, fluoro plus anatomical landmarks, D, angiography with contralateral access, and E, puncture with a wide crossover. So please, could you vote? And meanwhile, after these votes, we're going to start with the first presentation, which will be about ultrasound guidance. So we already saw the results up there. That's it. So more or less very more or less the same. We didn't have anyone with any particular preference. We're going to address that just now. So use techniques to gain femoral access. The first thing we have to know is, of course, as the questions show, there's more than one way for you to do things. And the thing, we always have in mind two questions: to be the most precise first, and to have less complications. That is not only in femoral access, but as well in any kind of procedure we do. And for that to happen, the first thing I would like to recommend you is each time you're gonna go for femoral access, or the first thing, you have to know your patient. So the first thing is check the patient, look at the patient, look at the previous exams you have. So the prior study you do to any patient is very important and will be of utmost importance. So while we wait for the first presentation to be loaded, we've all had difficult patients, we all had difficult anatomies, so it's essential for us to be able to have our homework well done. Can I have just the presentation, the first one, please? Okay, thank you. So, as I was saying, techniques for femoral access, we have anatomic references, historically what we used to do, micropuncture, fluoroscopy, femoral angiography, and after that we could, with fluoroscopy, you can also, as it was in the question, you have the crossover wire, and the ultrasound guidance has been one of the most used techniques nowadays. As it is obvious, as I was saying to you previously, it's important to know your patient. So you have to do your homework, as it is obvious. You have to know if the femoral has been punctured, or if we're doing a transaxillary, has had any problem with the transect, any kind of complication, any kind of injury that would make our work much harder, and the results won't be that good. Is it possible to use this type of closure device or that type of closure device? You have to know them all. You have to know the tips and tricks of each, so that you can do a proper choice of what you're going to use. If there is a problem, if there's a very fragile woman with lots of calcified disease in the vessels, if we have the problem of possibility of bleeding and so on and so forth, and important to know if you can, all these questions. And for us, at least, in my expertise as far as it is, I found that the prior CT scan is essential for me to know what am I going to be presented with. So if you could do a good study, in this case, is the software we use, we can easily go and check every centimeter of the femoral and iliac arteries and can foretell if we're going to have sites of complications, where's the calcium, where are the strictures, how is the angulation, and all of this is something we have to bear in mind so that you can choose what you're going to do. Of course, you have to, before that, know the anatomy of what you're doing. We have to know where's the inguinal ligament. You have to know we want to puncture the common femoral artery. We don't go below the bifurcation. We don't want to go upper and don't mess with the epigastric artery. So this is anatomical landmarks. But it's not so easy if you have a large patient, obese patient with lots of different landmarks. And the angiography normally is very useful, and we do know exactly that most of our target zone will be exactly on top of the bone, so that you can have the most compressible place, and it's probably where you have less complication but with bifurcation. But still, we have some patients in which sometimes it's lower, sometimes it's higher, and so we need to know what we're doing. And this is, I was saying, most of the times, if you go in the mid of the femoral, you won't have any femoral artery in the mid. Why are we talking about ultrasound after all these things we've been talking? Because we have the FAUST study, and we've had lots of randomized clinical trials about the use of ultrasound guidance. And what's the top most important is that they all show that if you do use the ultrasound, you'll be able to reduce the time to access, to reduce the time of attempts, reduce the risk of the punctures, and the vascular complications will be less, especially in patients with high common femoral artery bifurcation. And therefore, I'll show you today a quick film showing exactly why what we use nowadays. We use the ultrasound, we can see the calcium or not, and we always do it together with the fluoroscopy to make sure, besides we're being in a good position for the artery without calcium, we're still in the place where it's more compressible. Sometimes with the ultrasound we have a beautiful artery, but we're still too high or still too low in the groin. So it's important to do it in the conjunction of it all. So always with the echo, always injecting, and then you can see exactly where we're leading the, you can see the lidocaine going in, so you can be precise where you want to be. This is a short axis view. You can do it a long axis view, so you can see the vessel in the way. And we can, with this, be exactly precise where we want to do. In a 1 centimeter square place, we can go and puncture exactly what we want. and that's it. And so, take-home message, things for you to bear in mind. Puncture, always in common femoral artery. Be careful with bifurcation of the femoral artery, external iliac and inferior epigastric. Every time we mess with them, we have problems. Anatomical references, as I showed in one slide, can be very misleading. Fluoroscopy and angiogram can underestimate the calcium and arterial depth. And with the echo, we can know exactly it's 2 centimeters below the skin, and so we're much more precise. And the use of ultrasound combined with fluoroscopy, nowadays, it's our gold standard. Thank you. I hope you have a good message from this ultrasound guidance.
Thank you, Tiago. So I will present Dr. Cláudia Jorge from Hospital de Santa Maria, who is an interventional cardiologist. And before her presentation, we have the question in your screens. My most commonly used closure device is MANTA, the use of 2 ProGlides, the use of only 1 ProGlide, a combination of the ProGlide system and an AngioSeal, or the good old ProStar. So you can vote now.
And we've been through all of them in this past 10 years, I'd say. And they all did the trick in some of the patients, but in others we tend to, I don't know, what do you think? We've had a trend through some kind of large bore device closures towards others. You think it's because of the complications or because of the ease of how to use? Pedro and Henrique?
Mostly because we didn't have a good solution with the ProGlide. For instance, I was looking at option number D, and option number D happened many times as a bailout, because we tried to use ProGlide and at the end it didn't work, and we had to use an AngioSeal on top of already 2 ProGlides. So in my experience, I used a lot the ProGlide, but when we changed to MANTA, the complication rate went down. So I think.
So we have the results. MANTA is the favorite. We can discuss this later on. Now we have Dr. Cláudia Jorge will talk about the ProGlide device closure.
Olá, bom dia a todos. A mim pediram para vos falar um pouco sobre a utilização do ProGlide para o encerramento de arteriotomias de grande calibre. Na maioria dos centros, tal como já acabou de ser referido, utilizava-se o ProStar para conduzir ao encerramento de arteriotomias de grande calibre, mas este foi de uma forma praticamente rápida, substituído pelo ProGlide. Este é um dispositivo que é mais fácil de utilizar e, em mãos experientes, conduz a melhores resultados. Vamos ter menos complicações vasculares major, vamos ter menos hemorragia major e, consequentemente, vamos ter menor lesão renal aguda, assim como a menor estadia durante o seu internamento. Apesar disto não se ter traduzido de imediato por uma redução em termos de mortalidade, quer a imediata para o procedimento, quer a 30 dias, sem dúvida alguma, traduz por, a médio prazo, estar associado a um aumento da sobrevivência. Este é um dispositivo que eu julgo que dispensa uma apresentação básica, mas de uma forma geral é constituído por suturas, com nós de suturas que já estão pré-formadas e que são avançadas para a parede do vaso e que vão conduzir ao encerramento final da arteriotomia, que é uma arteriotomia de grande calibre que pode ir até 26 Frenches. Devo dizer que este não é um dispositivo dedicado para arteriotomias de grande calibre. Inicialmente foi desenhado para arteriotomias até 8 Frenches, com a utilização apenas de um único dispositivo. Atualmente, na maior parte das vezes, é utilizado mediante 2 dispositivos que são aplicados quer paralelamente ou então em angulação, com 45 a 60 graus de diferença entre os mesmos, mediante uma técnica de pré-encerramento antes da inserção da bainha de grande calibre. Tendências mais recentes conduzem apenas à utilização de um único dispositivo, portanto, um único ProGlide para arteriotomias até 14 frentes, e como podemos verificar, os resultados não são inferiores à utilização de 2 dispositivos, ou então uma técnica combinada com a utilização de um perclose ProGlide e um dispositivo de encerramento por plug, tipo angiosil, em que inclusive verificamos que esta associação de 2 dispositivos com mecanismos diferentes conduzem a menor estenose e também à necessidade de menos técnica de bailout. No entanto, como foi pedido para falar-vos um pouco de facto da técnica básica da implantação do perclose ProGlide em arteriotomias de grande calibre, trago-vos aqui um pequeno vídeo em que podemos verificar a implantação de 2 percloses ProGlides com técnica de pré-encerramento e com angulação entre os mesmos. Este dispositivo é avançado para o interior da artéria mediante apoio com fio J e posteriormente, obviamente, é removido. É muito importante a verificação de que o sistema dispositivo está no interior, no lúmen da artéria, o que é verificado através do braço lateral pela saída do sangue, que permite que os pés, sabemos que os pés estão no interior do lúmen. Posteriormente, após a abertura dos mesmos, é aplicada de facto as agulhas. Aqui verificamos uma técnica em que efetuam 3 vezes para ter a certeza que existe a aplicação direta em situações que existe de facto cálcio ou suspeita de cálcio ao nível da parede da artéria, e posteriormente há o corte dos fios e também à posição dos mesmos. Estes mesmos fios, há a destacar um fio azul, que é o que corre, e um fio branco, que é aquele de facto que vai travar o nó de sutura que já está pré-formado no dispositivo. Aqui verificamos que de facto os operadores estão a puxar os fios, isso implica que o nó está a correr, está a descer e está a ficar mais próximo do vaso. De seguida, através também de fio J, ocorre a substituição, retirada do primeiro ProGlide e, consequentemente, a aplicação do segundo. Geralmente, entre o primeiro e o segundo, com técnica de angulação, existe, de facto, a colocação mais ou menos o primeiro às 10, o segundo às 14 horas, que é o que nós verificamos que está aqui a acontecer. E agora vamos verificar que está de facto a rodar o dispositivo, que está intraluminal, e só depois é que de facto os pés são abertos. A aplicação das agulhas, com a técnica novamente de 3 introduções, o corte e o puxar dos fios que vão fazer com que a ança, com que o nó está pré-formado, passe através do interior da parede do vaso, e mais uma vez o puxar dos 2 fios para aproximar apenas o nó, não o encerrar, que de todo não é o objetivo nesta fase, e posteriormente então a saída e remoção deste mesmo dispositivo, para então permitir que entre então uma bainha de grande calibre. E esta é, portanto, a técnica de pré-encerramento. Entretanto, a válvula foi implantada e é necessário então proceder ao encerramento. Este mesmo encerramento temos de facto a utilização de também um fio J que fica no interior do vaso, e com o mesmo vamos proceder ao encerramento dos dois dispositivos. Nesta situação, vamos colocar o pusher apenas no fio azul, e este vai ser introduzido de forma a que o nó fique apenso à parede do vaso, e ao puxar com a mão direita o fio branco, vamos então te conduzir ao encerramento do nó. Como nós podemos verificar aqui nesta situação, ainda ficou de facto uma hemorragia residual, o que nesta situação, com a técnica dos 2 ProGlides, permite de facto a utilização de um terceiro dispositivo em bailout. E foi de facto o que foi aqui utilizado, em que foi utilizado um dispositivo de plug, o angiosil, e que permitiu uma hemostase adequada, como podemos verificar em angiografia final. Obrigada.
Thank you very much, Claudia. It's been a brilliant presentation. And I think we're going to go for the next presentation, and afterwards we're going to discuss them both. So we had a pre-closure device now, so we had the ProGlide, and now we're going to go for a post-closure device, like it will be Manta, will be Dr. João Brito presenting us his insights.
Thank you. So as Tiago said, after the pre-closure technique, we have a new player in the market. So in TAVI, ancient times, we had the ProStar. It had a demanding learning curve. It was prone to complications, to vascular complications and bleeding complications. This technique evolved regarding the implantation of TAVI, evolved to the use of the 2ProGlide, which I know is still the most common closure technique and the most common device used in cath labs worldwide. But we have a different approach for the closure of large bore vessels, which is the Manta, which is a collagen-based system. We have two different devices for different sizes. The Manta 14 French, which is able to close 10 to 14 French sheath insertion, but the outer diameter of the sheath may go to 18 French for the 14 French device. And we have the Manta 18 French that is able to close 14 to 18 French sheath, but the outer diameter may be up to 25 French. So in this point of view, the Manta, both Manta device may close 10 to 25 French access sites. So it's a wide range of devices that may be used. So we have the components of the package with the Manta closure device. We have a Manta landing dilator, which allows us to measure the depth of the puncture, and we have the sheath with the introducer. So this is a system that resembles the angioseal, because we have an intravascular polymeric toggle, which is resorbable, and it stays inside the lumen of the artery, which is connected by a polyester suture to a collagen plug. The collagen plug stays outside of the vessel. It helps not only to close the puncture site, but it also activates the coagulation pathways, which aids to a quicker hemostasis. And we have a stainless steel lock that helps to secure on site this combination of collagen plus the polymeric toggle, and it kind of makes a sandwich inside and outside the vessel, allowing to close our puncture site. This is a nice comparison between the different devices, closure devices, and you can compare the Manta 18 French, the size of the collagen pad and the size of the toggle. We can compare it, for instance, the angioseal, which is very well known for every interventional cardiologist. This is a scheme. We have first to measure the depth of the puncture, and then the deployment, the depth of deployment will be that measure plus 1 centimeter. Then we introduce the Manta closure. We rotate that lever at the deployment depth that will release the toggle, and then we'll tamp the collagen pad with that blue tube, and if the hemostasis, we assess the hemostasis, if it is safe and no bleeding, it is really very quick. We release the tension, and the tension that we apply to this system is also, we can assess it through a collar, a code collar in the handle, and when it's green is great. So we can tamp the collagen, we can release the tension. If everything okay, no bleeding, we can cut, we withdraw the system. We remove the guide wire. We have to do this always in a 45-degree angle. It's very important. And we remove gently and slowly the wire, cut the suture, and check by angiography if everything is okay. We have a list of devices that we can use. Basically, we have all the devices, the prostheses, TAVI devices that we nowadays use in our cath labs. Most of them are used with the Manta 18 French. There are two type of devices in which we can use the Manta 14 French, which are the Evolut R, the previous generation of the core valve, and the new Portico Flex Nav. The 23 and 25 devices have a 14 French profile, so we can use the Manta 14 French. There is not much robust evidence concerning the Manta. There is an ongoing randomized control trial. So I brought you a study that was performed in our center. To this moment, we have performed 280 procedures with Manta. This is a propensity matched population study comparing Manta to ProGlide. We use 140 Mantas. There were no difference regarding the composite endpoint of bleeding complications and vascular complications between the two devices, but the Manta reduced the time, reduced the need for an additional closure device. And it's a much more simple procedure. It saves us time. We don't have to do the pre-closure, so it really saves time during the procedure. And the learning curve is very quick, and quickly we learn how to use without complications. I have different examples. We can use it also in another large bore access, which is the axillary artery. As you can see, there is a radiopaque marker. It's a stainless steel radio marker. We can check that little black dot in the axillary artery. Also an interesting case that we use, we have two Manta in both femoral arteries. You can see the radiopaque markers both in the right femoral artery and the left femoral artery. It was the left femoral artery, it was a bailout procedure because we couldn't advance the Sapien 3 that was already inside the aorta of the patient. We couldn't advance through the aortic valve, and we had to perform a predilation with a balloon. So we had to introduce a 12 French sheath in the left femoral artery, and we performed the closure in the end with a Manta 14 French. So also a nice case to describe it. And just a little tip and trick, it can be tricky to advance the Manta sheath with the 035 wire in the end of the procedure. If you have a very severe tortuosity, this is not the case, but if you have a very obese patient, really obese patient with a big depth of puncture, it can be really tricky. We'll struggle to advance the sheath, so it will better use, and that's what I do, and in our center we do. In our current practice, we use a extra or a super stiff wire to give us more support. Thank you.
Thank you, Dr. João, for your great presentation. And I'd like to take this moment to present our two panelists at home. So we have Dr. João Alberto Rodrigues and Dr. Bruno Silva. I hope you're listening. from home.
Yes.
They'll be joining our presentation.
Yes, I'm listening. Thank you.
Welcome.
Me too. Good
Welcome
morning.
both.
Good morning. Welcome.
It's a pleasure to have you with us. Questions? Does anyone have any issues? I have always, one of my most difficult questions is, in large bore access with lots of calcium, which is your first choice? Henrique.
The problem with calcium is that devices that need a needle to cross the arterial wall may struggle more than plugs that stay on the outside of the artery. But on the other hand, plug devices, if they fail, especially the Manta, if you cannot cross, if you have a bad hemostasis, you kind of struggle because you don't have a plan B. Mm-hmm. So I think I tend to use a ProGlide, a pre-closure. If it goes okay, fine. If it doesn't go okay, you still have a plan B, which will go for a Manta device. So I tend to try a suture.
So a ProGlide, that's what you're using today?
ProGlide, a single ProGlide will do nicely. If I can put a ProGlide on a calcified artery, I'll be happy. Mm-hmm. I won't try a second.
Sometimes we have that palpable feedback when you're trying to deploy the ProGlide. If it's lots of calcium, if it goes through or if it doesn't. So that's an easy question, and it's a good answer. Can I, back there, Dr. João Alberto, could you... Dr. José Alberto, sorry. Can you give us your insight?
Thank you. First of all, I would like to congratulate the presentations. Very nicely done. I enjoyed everything, and I would only like to stress, it was shown on a slide by Dr. João Brito, but I'd like to stress that when we talk about 14 and 16 French introducers, we are really talking about expandable introducers. And so, depending on the valve, they can go up to more than 20 French when the valve passes through the sheath. So the pre-planning is also very important with the CT scan, as you told us in the beginning, because the size of the femoral artery, particularly if it has some calcification in its way up to the iliac, it's very important to know that the valve going through an expandable sheath can go up to more than 6.5 millimeters. As the devices that we currently use, we prefer to use the ProGlide, and in second choice, we can use ProGlide and Angioseal. Only in very selected cases, we use the ProStar. And with the Manta, unfortunately, we only had 2 cases when they presented us the device, and we cannot talk about the experience in this situation.
Okay, thank you so much for insight. So, and from Gaia, we're going to Funchal. Dr. Bruno, your insights about this issue?
Well, I pretty much agree with everything that was already told. First of all, good presentations, congratulations. And the point here stressed, we do have a majority of cases done using 2 ProGlides. Some cases we have done it with 1 ProGlide and it goes well, especially when you don't anticipate much calcium or complicated access through the CT scan. And we've had some presentation and some cases done with Manta. I think it's something about learning curves. Okay, so I think either techniques have good results when you apply them well. The things, the question stressed here by Dr. Henrique Mesquita Gabriel is correct. So when you use the manta, you kind of don't have a plan B. So you have to be very precise using it. But and with the ProGlide, sometimes you can have other choices still. You can have the access to the femoral artery, and you can do other closure devices, repeat the ProGlide or other plug devices. Still, I address that Manta has very nice results, and when used fine, I think it's going to be a great device.
Thank you, Bruno. Just a quick reference to the first presentation about ultrasound guidance. I would like to ask Pedro, what is now the current technique that you use, if you are familiar to the ultrasound guidance, and if you think it is worth it and it's a good thing in our clinical practice nowadays.
I think it's a good option to have also on the cath lab, although personally in most of the cases that I do, I still use the planning with cardiac CT, and then I perform the angiography and use the reference on angiography to do the puncture. With good planning with CT and with angiography, you can also do the case. I like to use ultrasound very much in cases that I do venous access. For instance, in the Pascal case of yesterday, and every time we do a large bore access for veins and we are just planning to puncture the vein, especially in this case is mitral clip, Pascal, and even mitral valve balloon valvulopathy. In those cases we use ultrasound so we can have a nice clean puncture of the vein without puncturing accidentally the artery. So I think in those cases it's very useful to use ultrasound. In cases that you just want to go to the artery, if you have a good guidance of angiography, you can also do it. So in those cases, many times I still use angiography alone.
Yes, and I think that's a very common opinion, because I talk to a lot of operators, and most of them tell me the same, that with the pre-planning with the CT and with the fluoroscopy, we can be really very accurate in the site of puncture. And we can avoid most of complications. Tiago, you are a big fan of ultrasound guidance.
I'm a big fan, and
what do you have to say about it?
It is very easy to do it in an easy patient, just the puncture with as we were telling about. The thing is, we've been seeing more and more difficult cases. That's what starts getting to our cath lab. And in the most difficult cases, and with a short window or space for us to puncture, if we have lots of calcium on one side or on the other side, it's very reassuring to make sure you know you're doing your puncture in the precise millimeter you want to do it, exactly above, 1 centimeter above, 1 centimeter below the exact place. And it's very less time consuming. And once you go through the first scope of learning the curve, it's very safe. So safety first, and that's my idea.
I think it also depends on what is the status of your learning curve. For instance, for younger operators that are learning TAVI, I would recommend them to use ultrasound, because they are not used to do femoral puncture, because nowadays almost all our procedures are done by radial, but I've been trained, and Henrique also, in femoral as a default approach. So most of our procedures were femoral normally, in the cath lab, so it was a routine procedure to do a femoral puncture. So we are very used to that, because we can have the feeling of when you are crossing the wall of the artery, for instance. But for younger operators that are not used to do femoral puncture, I think it's much more safer to do ultrasound guidance.
I always do, as I told you in my presentation, both. So you always have the ultrasound to choose the best place of the artery, but then always the fluoroscopy to know exactly where I am, so that I can be in the head of the femur, so that it's the place where we want to everything to roll up.
So I think it's time to move on to the favorite part of the of these kind of meetings, which are the complication cases. Everybody likes it. So I will present our first lecture, which is an unusual and complicated case in the aorta, and it will be presented by Dr. Mariana Gonçalves from Hospital Santa Cruz.
Good morning, everyone. I would like to greet the table, the panel, the people at home, and thank for the invitation to be here. My name is Mariana. I'm a junior fellow from Hospital Santa Cruz, and I will present you a case of a twist and turn strategy for a complicated case of TAVI. This is, next slide, please. Okay, this is an 82-year-old male with a severe symptomatic aortic stenosis, electively admitted in our ward for TAVI. He was hypertensive and with a previous history of atrial fibrillation, under anticoagulation with a NOAC, moderate chronic kidney disease with a chronic mild anemia, and he presented symptoms of heart failure in a functional class of NIA 2 with a quite high NT-proBNP of almost 5,000. His AKJ was in sinus rhythm. He presented a left axis deviation but with no further changes. And his echo, as you can see here, showed a very dilated LV with a tricuspid aortic valve presenting a severe regurgitation, good biventricular ejection fraction, and no pulmonary hypertension. This was a low-risk patient with an STS score estimated of 1.8% and the risk of morbidity of 13%. He was presented in heart team meeting, and he was accepted for TAVI for age and for patient's preference. Here you can appreciate his invasive coronary angiography before the procedure. He had family history of coronary artery disease, and he also presents coronary disease. We can see that the proximal LAD had an intermediate stenosis, presented diffuse distal disease. The first diagonal also had an osteal lesion, an important osteal lesion, and the circ had also an osteal lesion that was moderate to severe. Never though, the patient never presented angina. Treating this patient would obligate for left main stenting, and it would ask the patient to remain in dual antiplatelet therapy. So the decision was not to revascularize. The NGOCT before the procedure shows a very high aortic calcium score of 1,000 and almost 200, good femoral axis with a minimal diameter of 9 millimeters for both sides, a good coronary ostia 8, and a mean diameter of the annulus of 30. So counting with this, we decided to implant a core valve, Evolut R, number 34, through femoral axis. But when we looked further for the NGOCT, we could see that there was a long way to go until getting to the annulus. And this could be seen during the procedure. As you can see here, the tortuosity of the abdominal aorta, the thoracic aorta, and then finally the curve and the angle of the transition from the thoracic aorta to the aortic arch. So the Evolut R was we tried to deliver the Evolut R under a support wire Safari 2, extra small. But then when we got to the arch, the difficulty rised, and as you can see, it was not possible to advance. Any ideas? Well, we had very experienced and wise operators in the room, and they did have some. They started by inserting a guideliner under an extra support wire, a supracore 35, with the aim of leaning the outer curve, the guideliner to the outer curve of the aorta, and then pull the delivery system by the inside angle of the aorta, but it was not possible. Second idea, using a body balloon technique with a PowerFlex Pro balloon used in peripheral angioplasties, also in the extra support wire that was already being used with the same aim to line it to the outer edge of the aorta, but also it was not possible. I would ask the people at home to vote. What would be your decision now? Option A, would you change the device for example, a Sapiens 3 valve that has more flexibility in the delivery system? Would you, option B, refer this patient for conventional surgery? Or option C, would you try to perform a second attempt with an alternative access? Well, very well. We all agree then. So the operators also thought about an alternative axis, and during the procedure they performed an angiography in the subclavian artery to perform measurements that were then confirmed by the CT, and that showed that it was possible to perform these procedures through a subclavian axis. Here you can see now the second procedure. The patient was again admitted in an elective way to perform a subclavian procedure. In the second film you can see that the Evolut R was being implanted with a good position. And in the third image, the final result with very mild regurgitation and a good valve expansion. What did we learn with this case? First, that the aorta tortuosity should systematically be evaluated in different views, mainly the sagittal plan, before deciding either the valve replacement strategy and the axis. That the aortic arc length is not the only determinant of the success of the crossing. For each curve that the system crosses, the torqueability of the delivery system reduces. And that body balloon and snare techniques can be used to push or pull the system, but care should be taken when performing very aggressive maneuvers against the aortic wall, especially in these old patients with diseased aorta. Thank you very much.
Thank you, Mariana. So we'll discuss this case later. We'll move on to the next presenter. I'm glad to present Dr. Cláudio Guerreiro. Thank you so much for being here with us, even if remotely wise. From Hospital Vila Nova de Gaia, Dr. Cláudio Guerreiro.
Hello. First of all, I would like to thank you for this opportunity to be here presenting this clinical case, and I would also like to congratulate the excellence of the organization of this 2VRT meeting. Can you see the slides? Okay. This is a clinical case of an 81-year-old male, independent with well-preserved cognition. He had history of ischemic and valvular heart disease, 3 vessels disease, and severe mitral regurgitation. He undergone CABG with a limit to LAD, a saphenous vein to DP, and another saphenous vein to obtuse marginal artery. And also he had a replacement of mitral valve with bioprosthesis in 2008. He also had, in past medical history, permanent atrial fibrillation and peripheral artery disease. He was referred to our center because of severe aortic disease, severe aortic stenosis with moderate aortic regurgitation, with preserved left ventricular ejection fraction. He was in NIA class 2-3. During the procedure planning, we repeated the cardiac catheterization, which showed patent bypass from Lima to LAD without lesions, also the saphenous vein to the DP patent without lesions, and the saphenous to obtuse marginal artery occluded. Regarding the native coronary artery circulation, there was critical stenosis in the proximal LAD of 99%. The left circumflex artery hadn't have any lesions, and there was diffuse disease in the right coronary artery. The transesophageal echocardiography showed normal positioning and normal functioning of the mitral bioprosthesis, and we can appreciate the severe aortic valve disease with severe stenosis, with calcified leaflets, and also the central jet of moderate aortic regurgitation. And the global left ventricular ejection fraction was preserved. The TAVR procedure was planned as usual with the cardiac CT, which showed aortic annulus with an area of 450 square millimeters and 76 millimeters of perimeter. The coronary height showed the left main with a height of approximately 10 millimeters, so in the limit. The aorta had tortuosity, and also we can appreciate a steep angulation in the aortic isthmus segment, and also diffuse atherosclerotic calcified disease. Also in the proximal segment, or proximally to the aortic isthmus, we can appreciate also a calcified plaque, which could give us some trouble during the system delivery advancement. The femoral axis showed that the left femoral artery was more appropriate to the procedure, with less tortuosity and less disease, with a larger caliber to advance the delivery system. We choose a core valve evolute pro 29 millimeters for this clinical case through the transfemoral route, and see the vascular access that was pre-closed with 2-ProGlide. The first aortography with the pigtail in the non-coronary cusp that shows the calcified aortic valve and the aortic regurgitation. In the second image, we can see the advancement of the delivery system of the core valve through a Confida guide wire. We had some trouble with the passage of the system delivery guide of the system delivery when the system delivery crossed or tried to cross the aortic isthmus. Here we can see a kinking of the nose cone in the distal tip of the system delivery. We did much time. We retrieved the delivery system, and the patient became immediately hypertensive. We performed aortography immediately, and we can show the catastrophic complication of an aortic rupture with extravasation of contrast. Now, I would like to pose this question: how would you manage this complication? Should we call cardiac surgery to perform to go emergently and solve this complication? Can we assume that this is a fatal complication and there is nothing to be done? Try to solve this complication with a stent graft, with an endovascular stent graft, or prolonged balloon inflation and medical management, because this is a contained rupture. So a balanced opinion, but with more significant votation in the endovascular aortic repair with the stent graft. Effectively, we advanced with that strategy. So we deployed the Valiant thoracic stent graft of 38 millimeters, and after the deployment, we thought that there was under expansion in the proximal segment of the stent graft, and also we believed that there was not a total cover of the aortic rupture. So we performed a pause dilatation with a compliant balloon that accompanies this stent graft. The patient stabilized, so the transient hypertension resolved, and as we had already the core valve mounted, we rapidly advanced with the core valve implantation without any additional complication, and the final angiography showed no significant leak or gradient. We closed the left femoral artery without any access site complication, and we believe that that was the end of the clinical case. Obviously, we had a problem to solve with the revascularization of the supraortic arteries, but we thought that we had time to do it because the patient was very well. That was not the case. After closing the vascular access, the patient collapsed. There was a sudden cardiac arrest in electromechanical dissociation. Immediately, we begin advanced life support maneuvers with intubation, mechanically invasive ventilation, chest compressions with a mechanical external compressor, and we performed an aortography that showed that there was not occlusion of the left main coronary artery. There was also not apparently extravasation of contrast that could point to de novo aortic rupture, and also we advanced a system of temporary pacemaker to try to solve, eventually to give rhythm support. It could be eventually the problem, but unfortunately that was the end of the case, because the patient did not perform well despite our intervention, and the patient died. The main hypothesis that we think that could explain this outcome, probably it was the exclusion of the left subclavian artery with the stent graft, compromising the flow to the extended territory of the LAD, because the native LAD had a critical stenosis of 99% in the proximal segment, and as we compromised the limit to LAD flow, probably that could be an explanation for this outcome. As final messages, I would like to stress that although the experience with TAVI is increasing worldwide, there remains a risk of potentially catastrophic cardiac or aortic complications. And significant injuries to the aorta in this context may require open surgical repair, but we have to remember that these patients are challenging. They were challenging in the beginning with very often a prohibitive surgical risk. And in this case, an open surgical procedure to solve the problem could be limited by the limit to LAD graft. In cases with calcified or highly tortuous aorta, we know that there is an increase in the risk of vascular complications, and it should function as a red flag to the potential occurrence of it. So we have to think that probably, and we are looking now in retrospective, probably we could begin the procedure or advancing the delivery system, anticipating the difficulty in the crossing of the aortic isthmus with an extra stiff guide wire or a buddy wire or a buddy balloon. So another option that could increase the support in the system delivery advancement. Immediate repair with an aortic stent graft inserted peripherally could be a life-saving treatment. We hoped that it would be the solution for this case, but there are some caveats that should be remembered. In this case, we didn't have time to think in the revascularization of the supraortic vessels. That probably could be the final problem of this case and resulted in this unfortunate conclusion. Thank you.
Thank you, Claudio.
Thank you, Claudio.
Maybe we could ask Dr. Alberto Rodrigues, what is your opinion about these two cases? If you have any, I guess that you are aware of one of them and you know one of them. What are your comments?
The roller coaster one, I'd say.
What are your comments on these two situations, challenging cases?
Yes, thank you. I must declare my conflict of interest that I was present in the case of Dr. Claudio. I think it's very good to place aortic complications in a session like this, because it's one of the situations that can be really dramatic and can really disturb the procedure. So we must take this opportunity to learn. As always, we must learn from the pre-planning. And if we see the tortuous aorta, the calcified plaques in the Claudio Guerreiro's case, that were one of them, if you see on the CT, the length of aorta, one of them was exactly in the most angulated curve after the isthmus. Now, afterwards, we can think about other strategies or other access sites, but it's important to remember that follow the valve as it goes up the aorta and mainly as it crosses the arc. Do the maneuver with the angulation to perfectly see the advancement of the valve. And if something doesn't go well, or if the wire is not stiff enough, very well placed, stop and rethink about it. As the case from Santa Cruz showed us, we can try to change the wire. For example, in the Gaia's case, we were with a Confida, I think, but there are other wires that give better support, like a backup wire that we have in our laboratory now, and the Landerquist wire, which we didn't have back then, but now we have. And so there are some tricks and attentions that we must pay now. Another thing that we can, after the problem surges, it's how to fix it very quickly. That was the stent graft most rapidly placed that I have ever seen. We fortunately had the stent grafts in our lab, so we just have to grab it and immediately place it. We had also the femoral access was already placed, so that was very quick and really stabilized the patient. And it remained stabilized for quite a while, because during some time we thought that we would interrupt the case. But then the patient was so well, between commas, of course, that we decided that anything else that we would do on him, we'd better do it with the valve disease solved than with the problem of the valve still there. And so we advanced and placed the valve and closed the case. Unfortunately, it was very rapid after the closure of the access, the collapse of the patient.
I think we lost.
The may have been compromised, must have played an important role. But I think that from both cases, we can learn some tips and some points to be very attentive, not to pass through these things again. Thank you.
Okay, thank you, Dr. Silva. I'd like to pose a question, and as we discussed, but still both cases. In the first case, the second charge of axis, you saw it was transaxillary. What's your opinion, and what are the issues that make you change the femoral axis, which is our primary access point, and which is the the second access site you use most. The key issue that was said a little while ago, we don't all have valent captivia in our cath lab to put it just straight away. That's something maybe Dr. Henrique will address us in the end, the toolbox we need to have in our cath lab. But as we discuss it, if you can, maybe Dr. Bruno, tell us, as you comment both cases, what is your alternative access number 2?
Yes, well, our access, preference access is femoral. When we don't have it, we try to do it through the subclavian artery with the help of the cardiothoracic surgeons, of course. And we don't have many cases done like that because usually femoral is fine. As for comments for the cases, I just wanted to add a comment to the discussion. Of course, the first case had a lot of tortuosity in the aorta. You could see it in the CT scan. There is a detail in the Medtronic delivery system of the Evolute. There is a marker because the catheter is it only is more flexible in one direction. So it has two spines that if there is a landmark, a marker in the tip of the catheter, and we always have to be also pay attention to that. Of course, that sometimes with so much tortuosity, you are unable to rotate or to give it a 90-degree, let's say, rotation, and it will respond because it loses torque, it loses the strength. So that's something I just wanted to ask if you tried that maneuver. And afterwards, I think you thought very well, and you went through a secondary access, and it's you put it much more easier for yourselves, and you done it. The other case, I think it's a very complicated case, and you tried to solve it in the only way I think it would be possible to solve, and that's it for my comments.
Thank you, Bruno. Henrique, would you like to, or Pedro, would you like to comment?
One comment on the first case, because on the options that we had to vote, it was the option of using also an Edwards valve.
That's what I was going to ask.
I was thinking about that, but because we can play with flex, and it might go a little bit further, but you might end up having a second problem, because if it doesn't cross the valve, you have to put everything back again, and it might be very difficult to bring the valve after being mounted on the balloon to take it out of the patient, and you might
both
lose
the
access.
sheath and
perhaps you might lose the access and everything. So in this case, I wouldn't use also an Edwards valve. In the second case, I had also a rupture of the aorta, but fortunately it wasn't on the abdominal aorta and not on the thoracic. And we were able first to put a balloon just to stop the bleeding, and then to implant a covered stent. We used a balloon expandable stent, not a self-expandable. I would love to have this in the cath lab and immediately available to put. In our case, we had to use a balloon expandable, and we have to crimp the stent on the balloon, so we have it takes some time before we did that. If I remember well, this stents from the Valiant, the first part of the stent is not covered. So just after the first ring, it becomes covered. So it might occlude or not the subclavian artery or even the carotid, depending on the distal place where it starts to be deployed. Of course, in an emergency situation, it's very difficult to have landmarks and to know exactly where we can start deploying this kind of stents. And I perfectly understand the operators. They want to put immediately to stop the bleeding, otherwise the patient would be want to resist this complication. But and if the subclavian was occluded, it might not be a problem, but because this patient had a lima to LAD, it might cause ischemia in that case.
Henrique.
I'll do a few quick comments. Mariana's case, I've been in a room. The Edwards valve would be a bad option also because of the size, because the valve annulus was really on the top limit of the Edwards valve. So even for the size, the Edwards would not be a solution. We had a case a few years ago where we lost a patient because we went to the strategy of strong wires, very strong wires, and we ended up rupturing the LV. So I don't like to increase or go up on wires when the problem is tortuosity, because I lose control on the left ventricle. So I can gain crossability, but I increase the risk on the LV. So I understand it's an option, but I don't really feel very comfortable with that option, because
it's a trade-off always.
It's a trade-off, but you're going to use strength to cross, and you lose control on the tip of the wire with a hard wire. So I think the best thing is to anticipate. You said very well, the core valve has a spine, so it flex on one plane. If you on a CT scan see there are multiple curves on one plane, that's fine. If the curves are on two different planes, the core valve is a problem. Then you can swap either to Edwards valve, anticipate, or even a portico that flex quite well on several planes. So anticipate and choose your valve accordingly. If you have problems with the valve, I know it's 30,000 euros, but you better save the patient. If the patient is awake, which I don't know if in the Gaia case was, if the patient complains, I really pay attention to the patient. If he complains, the aorta is talking to you. So listen to the aorta. Don't force if the patient is complaining. The other detail I would like to comment is, you went for a self-expandable stent, which is fine. We have more options. That's because of our setting on balloon expandable device, mainly because of pediatric cardiology use them for coarctations. And I don't know if it'd be a better option because you can implant it more precisely, a balloon expandable device.
And it doesn't need a landing zone as big. The problem with Valent Captiva
it depends on the size of prosthesis and etc. But roughly saying, balloon expandable stents, you can deploy them more precisely than self-expandable stents. But it really depends on what you have on the shelf and what the problem is.
Thank you, Enrique. I think we should move on to the next presentation. And I would like Bruno Silva to present his case. Bruno, be my guest.
Good morning again. First of all, thank you once again for inviting me to participate in the meeting. So my complication case is about iliac, and it's much more simpler than the previous ones. So this was an 84 years old female patient with a symptomatic severe aortic stenosis. She had a morbid obesity, so a BMI of 39 and a BSA of 1.83. She had hypertension, non-insulin treated diabetes, dyslipidemia. She had a severe chronic kidney disease and a degenerative osteoarticular disease. So the heart team decided for TAVI in this patient, and she was scheduled to do it in May 2019. This was her CT scan, so we almost immediately recognized that there's very amount of calcium and tortuosity. Looking for the right iliofemoral axis, we can see that there was not much room in terms of external iliac artery, with 4.9 millimeters in diameter, and there was a tortuosity, a curve in that axis. The left seemed to us to be a better choice because the minimal lumen was bigger, 5.7 in the external iliac, and it seemed to us that it doesn't have so much tortuosity. So our implant strategy was to do it through put an Evolut Pro 29 valve using the main axis, the left femoral artery, going through from 6 French, then putting ProGlides, 8 French, 12 French, and 16 French Entran. and having the secondary axis the right femoral artery with the 7th French. So we used in this case a fluoroscopic guided puncture. We usually have a pigtail, a crossover, and we do an injection and put also a guide wire to help us to determine the puncture site, and a pre-closure technique with 2 proglides. So this was the injection done through the right femoral with the pigtail to help us guide our puncture site, and the steps were like follows. So crossover with internal mammary catheter, and then change to a pigtail. Then do the fluoroscopy with an injection. You used a pre-closure technique using 2 proglides at 10 o'clock and 2 p.m. o'clock or 14 o'clock with an angulation, and we changed then to an 8 French and a 12 French placed in left femoral artery. Then when the operator was going to take out the pigtail and to put it in the aorta, the pigtail didn't came, so it felt like it was stuck. We've probably thought of tortuosity. We've put the guide wire inside the pigtail to prevent it, to give it more strength, and the operator pulled it a little bit more, and the pigtail came out. So the pigtail came out, everything fine, but the next angiography was this. So we had fractured the tip of the pigtail catheter, and it had a 0.035 inch guide wire coming from the right femoral artery inside. And now I'm asking, so what happened? So did you have a tortuosity? What was the mechanism of this? Tortuosity of the vessel plus manipulation fractured the catheter, or a catheter entrapment in a calcified plaques? Or do you think it might be the proglide insertion that caught the catheter? Or maybe the 12 French sheath insertion in the left femoral artery entrapped the catheter? What do you think, please? Vote. So, more or less divided audience, but still the majority of people think that there might be a question of the proglide insertion that caught the catheter. So, next question that I pose to you is how to fix it. So, with peripheral balloon inflated distally from the right femoral using the guide wire that was there, a long sheet from the right femoral to intubate like a mother and child technique. Do you snare it from the right femoral and pull the tip out? Do a mother and child technique with a balloon trapping inside the 12 French sheath from the left femoral artery, or simply take out the 12 French sheath or snare it to the 12 French through the left femoral artery? So maybe the one that seems more feasible to everybody was to do it like with a long sheet from the right, to try to intubate, like to put a sheet in over the tip and try to retrieve it like that. So let's see what happened. As an interventional cardiologist, whenever we have a guide wire inside something that we lose inside, we never want to take the guide wire out. So we try to manipulate the guide wire, and we put a long sheath through it, through the right femoral artery, but and do a mother and child. But there was always some difficult when you tried to bring it out. There was a point that it wouldn't came out. So we tried going further down distal. In the right video you can see it. We almost passed the distal tip, but we couldn't pass totally the distal tip of the catheter. And this was our problem, and now we were okay with the sheet inside, but we couldn't do it. Meanwhile, I don't have the videos, but first of all, we tried to advance a balloon, a peripheral balloon, but we quickly give up that idea because the peripheral balloon only put the tip further distal, the left femoral artery. We didn't do it. So we had to do a decision to take out the guide wire, and with a snare, we had the Terumo 45 centimeter destination 7 French sheath through the right femoral. We advanced the snare, and we pulled out we snared the proximal tip of the catheter, as you can see, and it kinked in a place, and doing some pulling, we kind of managed to put it all through the destination sheath, and voila, when we pulled it through the sheath and through the right femoral, the wires, the ProGlide wires in the left femoral artery just disappeared inside the left femoral artery and came out trapped to the catheter tip in the right femoral artery. So this was the confirmation about the mechanism of what was happening. So the ProGlide insertion was the culprit mechanism. So this is a take-home message that we want to stress, that always take out guide wires and take out the catheters, pull it up before doing the ProGlide insertion, because you can trap either guide wires or catheters. Unfortunately, also I don't have the photograph of the tip of the catheter, but you can imagine our surprise seeing the guide wire knots, the knots of the ProGlides in the tip of the catheter. So we proceed with the case. We did in the left an angiogram. Doesn't seem to us to have any problem, and we did the case. We implanted the valve, and in the right there is the final injection to see if everything was fine, and we were pleased, and everything went well with the case. Thank you.
Great, thank you, Bruno. Good case. Unfortunately, we're running a little bit behind schedule, so I'll go straight ahead with the next presentation. Dr. Ricardo Pinto from Hospital de São João will have a short discussion of these two cases afterwards, okay? Thank you, Bruno. And hello, Ricardo.
Bom dia. Vou-vos apresentar um caso sobre complicação femoral. E-vos pedir, pronto, já estão aqui os slides, só um segundo. Pronto, o meu caso é sobre um doente de sexo masculino, de 70 anos, cidadão holandês, que estava a residir há cerca de meio ano em Portugal. Com fator de risco cardiovasculares, apresentava apenas uma hipertensão bem controlada, com antihipertensor, sem outros antecedentes médicos relevantes, e tinha uma estenose aórtica conhecida, que tinha sido diagnosticada num eco de rotina, mas o doente era assintomático e não tinha tido nenhum seguimento posterior a isso. No dia 10 de agosto de 2020, ele é internado num hospital distrital do norte de Portugal com insuficiência cardíaca aguda, em choque cardiogénico, com um edema agudo do pulmão refratário, com necessidade de aminas. Nessa altura percebeu-se que o doente tinha uma estenose aórtica grave, com uma disfunção ventricular importante, com uma disfunção grave do ventrículo esquerdo e com uma regurgitação mitral também grave, concomitante. Foi discutido o caso com a cirurgia cardíaca e com o nosso laboratório de hemodinâmica e, portanto, foi decidido a transferência do doente para o nosso centro hospitalar de São João, no sentido de efetuar uma valvulotomia por balão aórtica como ponto para um tratamento definitivo. Pronto. E estas aqui são as imagens do eco transtorácico pré-procedimento. E temos uma estenose aórtica grave com um gradiente médio de 55, com uma área de 0,7. Foi feito também um eco transesofágico para perceber um bocadinho o mecanismo da insuficiência mitral, que se confirmava como grave por ruptura de cordas tendinosas, e também para medir o anel aórtico, que era de 26 mm. Temos aqui o segundo. E nesta imagem podemos ver na angiografia coronária que não tinha nenhuma doença significativa e, portanto, foi efetuada como planeado uma valvulotomia por balão aórtico. Inicialmente foi feita com um balão de 23 mm devido a uma calcificação marcada da aorta. Vamos ver aqui uma expansão adequada, sendo que posteriormente decidimos usar um balão de 25 mm. Vamos ver aqui inicialmente. Okay. E depois conseguimos uma expansão adequada. No entanto, no final da expansão houve ruptura do balão. Pronto, dado este contexto, decidimos, foi logo retirado o balão, mas qual não é o nosso espanto que é isto que aconteceu. Ou seja, em cima podemos ver o balão de 23 mm que está intacto, foi que tínhamos retirado previamente, e em baixo podemos ver o balão de 25 mm que estava fraturado. A parte da estrutura externa do balão não tinha saído e também a parte interior do catéter para a insuflação do balão com as marcas radioopacas não tinham saído e estavam dentro do corpo do paciente. Pronto. Neste contexto, fizemos fluoroscopia do corpo inteiro para tentar perceber onde estaria o resto do balão e felizmente percebemos que o resto do balão estaria junto ao introdutor femoral direito. Nessa situação, o que fizemos foi retirar o introdutor, só que o que aconteceu foi que saiu a parte interna do catéter com as marcas radioopacas que podemos ver aqui nesta imagem. No entanto, a estrutura externa do balão não tinha sido retirada, mantinha-se no corpo do doente. Pronto, nós que pelo acesso não havia hemorragia e também a palpação percebia-se que o resto da estrutura estaria junto à artéria femoral. Palpávamos, percebemos que havia lá uma tumefação. Ainda tentamos fazer algumas local do acesso, sendo que não foi possível retirar e, portanto, neste ponto decidimos contactar a cirurgia vascular e foi feita uma exploração do local da artéria femoral. Afirmou-se que o resto do material do balão estava embolizado na artéria femoral comum e foi retirada de forma urgente ainda no laboratório de hemodinâmica. Pronto, do lado esquerdo podemos ver a imagem da estrutura do balão que estava embolizada na artéria femoral e do lado direito podemos ver a estrutura toda do balão já fraturada. Pronto. Fora isto, de resto o caso correu bem, felizmente o doente evoluiu de forma favorável, temos o eco pós-procedimento com uma estenose aórtica já com um gradiente menor, um gradiente médio de 34, com uma área valvular de 0,8, dada boa evolução, com resolução da disfunção ventrículo direito, com melhoria dos sinais de hipertensão pulmonar. O doente foi submetido de forma favorável a uma cirurgia cardíaca cerca de 2 semanas após, com substituição válvula aórtica, substituição ventral e anoplastia tricúspide.
Thank you both. Thank you both the presenters. Thank you, Bruno. Thank you, Ricardo. Next presentation will be performed by Dr. Pedro Teixeira. Pedro.
Thank you. Good morning, everyone. Thank you for the invitation to participate in this great scientific exchange of knowledge. My case is a rather simple one. I will talk about the case of a transfemoral TAVI in a patient with peripheral artery disease, focusing mainly on anticipating some vascular access site complications. We have here a 78-year-old male. I'm trying to pass the slide, okay? A 78-year-old male with several cardiovascular risk factors and peripheral artery disease. I don't bring here the echo and coronary angiography images, so you will have to believe me when I say he has severe symptomatic aortic stenosis with preserved left ventricle function and no coronary artery disease. He had been submitted 2 years prior to the TAVI procedure to a percutaneous procedure by vascular surgery with covered stent implantation in both common iliac arteries, 2 via-band stents, and the hemostasis in the left side was not so well with the failure of the ProGlide system, at that time and the need of surgical debridement and direct suture of the arterial wall. Here we have our angio-CT procedure. We have here tortuous and very calcified right femoral artery. We excluded this excess site, and we have a not so healthy left femoral artery, but the minimum luminal diameter was not so bad, and we had not properly circumferential calcium, so we did not exclude a priori this excess site. But I would ask you a question: what would you do? What would be the excess site you will choose in this case? In the next slide, it would be the next question. We have here some more images of the angio-CT showing a good patency of both viaband stents previously implanted. But we must anticipate, even if we want to use the left femoral artery access percutaneously, that the scar, the fibrosis, and the stiffness of the tissues would potentially make difficult all the steps of the procedure. So I would ask you now, how would you proceed in this case with a transaxillary TAVI, transapical TAVI, possibly a transcaval access, transfemoral with the surgical cut down and obviously with the vascular surgery support, or a transfemoral TAVI with an ultrasound guided access and a ProStar pre-closure device? Okay, transaxillary TAVI seems a nice a nice alternative. By the time of the procedure, we didn't have so much experience in that alternative access site. But even though we must consider if it would be transaxillary, we wouldn't have a clinical case for this symposium on femoral arteries, and that is a good reason why we chose another alternative. We followed for a transfemoral TAVI. I don't manage to. Okay, so we have here an initial angiography showing the two stents patent and a left femoral artery with the guide wire in place in the second image, and the ProStar pre-closure device was applied, and the needles were drawn back here in the third image. So we used a ProStar, a suture-based pre-closure device, and we inserted a 14 French sheath. All the rest of the implantation of the valve were uneventful. So we pre-dilated with a 20 milliliters balloon, and we implanted a core valve Evolut R of 29 millimeters with good angiographic and hemodynamic result in the end. We have here the pre-implantation and the valve already implanted inside. And the final angiographic control showed the aortoiliac axis with no de novo findings, and the left femoral artery with good result also with this closure with ProStar, no stenosis, no contrast extravasation or other complications in the immediate setting. We have several studies comparing prospective registries and studies comparing the performance of those two suture-based pre-closure devices most widely used, ProStar and ProGlide, with very reasonable numbers of patients. And we show that in the hard outcomes, we have no difference. In the soft outcomes, we may have some slight difference in the performance of both these systems, but when we make propensity score matched analysis, even this difference, the majority of them are blunted. And the same is also shown in this recently published systematic review, when we have no difference in the all vascular complications outcome. As the final messages, I would say that peripheral artery disease does not preclude the transfemoral access for TAVI, but possibly these patients would be best managed in high volume centers with vascular surgery backup. The focus in the planning will be the anticipation and the prevention of potential complications. The puncture would ideally be the most controlled the setting possible, with echo guided puncture preferably. And the pre-closure devices, although have in non-selected cohorts of TAVI patients no relevant differences in their safety or efficacy profile, the truth is that we don't have data in this particular subset of patients previously submitted to surgical intervention. And we must remember that the tissue fibrosis, the tissue stiffness may compromise. And the focus of the case is essentially this. We must have this soft skill and this empiric knowledge that the two devices are not exactly the same, does not behave exactly the same, and ProStar may offer additional support in these challenging patients, in this challenging transfemoral access. Thank you all for the attention.
Thank you very much. And without further delays, we'll continue with Dr. Lino Patrício, currently Hospital de Évora.
Yes.
Thank you.
Thank you. I'm very happy to be here with this faculty, very young faculty, and I would like to address, eu gostaria de dar abraço ao meu amigo Pedro Canas, que esteve aqui, que não está aqui connosco neste momento, mas que eu espero que para o ano esteja cá, e foi dos primeiros a começar com esta técnica, e eu acho que temos que lhe desejar muitas felicidades e saúde para que para o ano possa estar aqui connosco. Now, the case is a little disgusting. I have the next slide here? Okay. So it is a 85 years old lady with an aortic stenosis near 3 with risk factors, hypertension, dyslipidemia, smoking and COPD. And it is a very tight aortic stenosis, no coronary heart disease, and a calcification, a very huge calcification of the aorta. And this is the CT. You can see annulus of 24 millimeters, and a very huge calcification of the abdominal aorta in the infrarenal space, and the iliac right was occluded. The femoral is 3, 6, and a huge calcification of the left iliac. And the subclavian artery is 2 millimeters. So we don't have an aorta and a thrombus, on the wall of the aorta. So we couldn't have the subclavian access, we couldn't have the transcaval access. So we decided the femoral access with a special technique. Actually, we did some cases of shock waves in coronary arteries, and we decided that shock waves, we saw in the literature this technique, and we planned the procedure with the vascular surgeons. So we go through the femoral for a shock wave technique. This is the CT, the calcification of the right iliac, and huge calcification of the aorta, and a very tight stenosis of the left iliac. So this is sorry, to move back. Okay. Oh, okay. Now, you can move the scene, please. Okay. This is a huge calcification of the iliac with a tight stenosis in the osteo of the iliac near the aorta, and a very big calcification in the aorta also. So we go first with a balloon. We did the procedure with the surgeon, and after we did the shock waves, 760, as you can see, and we put a covered stent. We tried to go through with a sheet, and at that time the patient is very stable, but we saw bleeding of the, sorry. Okay. And we saw a bleeding in the, now. You can see a bleeding now near the stent, in the proximal segment of the stent. And we decided, Pedro said, I saw your discussion before. At that time, I think that it is better to go to the valve and to put the valve and implant the valve, and we go very quickly to the annulus. We go with the core valve. We put it in without pre-dilatation, and we can see that the valve is not expanded. You can see here the valve is not expanded, and you have a moderate rigor. And we go with a balloon, 24, to pulse-dilate, and the final result is very good, as you can see in the right scene. Okay. So we come down to the iliac, to the aorta, and you can see now like a dissection and a huge broken of the calcium and escape of bleed. We didn't know what happened, but the surgeon said it is a very, very huge dissection, a very broken artery. So we go with a balloon to stop the bleeding, and we put a Viaband inside, actually two Viabands, 110 and 150, to stop the bleeding. We try to contain the escape, but really it was not possible. At that time, the patient is not very well, but not bad, not in shock. This is, and we see inside the Viaband like a bleeding. We don't know why, and we did a pulse dilatation, and this is the final result. Actually, we see some bleeding of the patient. The patient was very stable at that time, and we decided to stop the procedure. And unfortunately, the patient went to the coronary care, and we have a drop on the hemoglobin, and we did noradrenaline and blood and volume, but she was died in 12 hours.
Thank you, Professor Lee, for your excellent presentation. All these cases show us how diseased and how frail these patients that we treat are. Unfortunately, we are so way behind in our schedule. I guess we'll move on to our next presentation by Henrique Gabriel.
So we talked about a lot of complications of our accesses. We use large accesses. I'm going to talk mainly about what we need to solve these problems. I'll start by reminding us why we need a toolkit. We need a toolkit because we make large holes in arteries. When you look at TAVIs, the sizes go up to 20, 22 French. If you go to Impellas, depending on the models, you also go to around 20s French size, which is holes of 6-7 millimeters in diameter big holes. And big holes come with big problems. We know that on a clinical practice, this is very relevant. This is a recent meta-analysis of TAVIs. You see that around 1 in 10 patients has a severe bleeding, and about 1 in 20, that bleeding can be life-threatening. We know that the gear improved a lot, the sizes are smaller, the operators are more experienced, more proficient. If we look at the differences of complications before 2012 and afterwards, it really decreased to almost half, but still it's 1 in 20. It's not that rare. So what kind of complications do we have related to the access? We have occlusions, which can be solved usually not in an emergent way. If we occlude the femoral artery, we have several minutes, if not hours, to solve the problem. The patient will have pain after 10, 20, 30 minutes of occlusion, but really the severe complications like the involvement of the nervous system and paralysis takes hours to install, so you have plenty of time to try to solve it percutaneously or ask help from a surgeon. Occlusions are more rare than bleeding, and usually we can solve it from the same axis if the occlusion is above your introducer, or contralateral if the occlusion is at the point of access, which is most commonly the case. We tend to use mainly drugs, aspiration, anticoagulation, sometimes thrombolytics, and more rarely stenting or ballooning, which may in fact embolize further down and not really improve the situation. So try to solve it with aspiration and medication more than with stenting. Bleeding, it's a major concern because you have to treat it right away. You can have bleedings with a quite big volume. So immediate diagnosis is very important. You need to be aware and diagnose the problem so you know how to treat it. It can occur in several levels. We've seen them all today: aortic, iliac, infrarenal, subclavian, even collateral vessels perforation with wires. We've seen a case yesterday. How do we access them? Usually ipsilateral if it's high up, if it's in iliacs and aorta. We can use the introducer that we've set up for the TAVI. It's big enough. Use a 14, 16 French will help you to solve whatever you need to do if it's high up. You need to use a control access if the bleeding is lower on the iliac sometimes, or infrainguinal in the femoral, or with a crossover introducer. You even sometimes can use a very distal access. You can come from below on a femoral or from the arm to control the bleeding. I think it's easier from a mental standpoint and from a management of your shelves to group the complications depending on the site where it happens. So if you have an aortic bleeding, usually you're going to need bigger balloons and bigger stents. That means a 14 size French. Usually the TAVI introducer will do. You need a balloon, a big balloon, and we tend to use sizing balloons from the pediatric side, the NewMed or the Abbott balloons, which are very compliant. So as the size will inflate to low pressure until you see the bleeding stop. If you really short on material, you can even consider to use a valvoplasty balloon that you use in the aortas. I strongly recommend to inflate at the site of bleeding, because if you inflate above, you can still have bleeding from collateral circulation from below, and you reduce the problem, but you really don't control it. You may have to inflate above the bleeding if you cannot see where it is. So you can inflate above the bleeding and then angiography below, so you can really pinpoint where the problem is. On the aorta, balloon expandables are good options. The CP from NewMed or the self-expandable stents, there are several options. The balloon expandable stents usually allow you to be more precise where you want to deploy, especially if you want to avoid side branches like the renal arteries or the vessels of the neck. The self-expandable stents usually come on a longer size and you don't control as well, so use it on areas where the position is not that precise. You have just a short list. I'll go, you can see it later if you want, but basically the balloons and stents we can use, I've mentioned the most important to us on this setting. Iliac subclavian bleeding, it's a smaller vessel, usually on a 10, 18 millimeter diameter range. You can use your TAVI introducer, or if you need to put an introducer, an 8 or 10 French sheet will do. Balloon, just a normal peripheral balloon, about the size of the vessel will do. Use low pressure, you don't need much more than that. And then you can choose either covered stent, a balloon expandable, Advanta V12, it's reasonably low profile, or self-expandable stents, and really depend how precise or how long the need to cover is in that case. I made this graph when we had to decide which stents to have on the shelf, and basically what you see here is that the lower French size for a covered stent is the Advanta up until 10, which needs a 7 French introducer. If you need to use a self-expandable stent, the lower diameter will be the Gore until the 9, and beyond 9 will be the Fluency stent. The wall graph is always bigger. So smallest diameters will be the Advanta, and the bigger diameters will be Gore or Fluency. But the most common place to have a bleeding is at the femoral artery, is infraginal bleeding. Most of the times you need a contralateral access. It's very difficult to control the bleeding going from the same side unless you go well into the femoral superficial artery. You're going to need an 8 French sheet or a 10 French sheet. You can use radial or humeral with longer shaft balloons, not the standard ones, or on a smaller patient, you can get there from the radial. Inflate the balloon, gives you time to decide what to do. You don't see the balloon expandable stents on this list on purpose, because if you put a balloon expandable stent on a femoral, the femoral is a flexion point, the femoral is a compressible point from the outside. So the first time you're going to see if the patient has a pulse on the femoral, you're going to compress the stent. Nothing may happen, but I don't know if it's a good solution. So really the options will be a self-expandable stent, as we talked about, or surgery. I'll remind you that surgery on a femoral artery is usually a simple procedure. It can even be done with local anesthetic, and it's a very elegant solution to give you full control. And some of us would do valvular TAVIs for more years. Remember that at the beginning a lot of centers used surgical access to the femoral as routine, so it's not something out of this world. I'll leave you the table with the diameters of the Fluency and the via bands, just so to have an idea of the introducer size, but basically they go from 8 introducer or 12 if you go beyond 8 millimeters or 9 millimeters diameter. The self-expandable stents should be at least 1 millimeter larger than the size of your artery, of your target vessel. So in conclusion, to keep it fast, bleeding complications are not rare, and most can be life-threatening, so it's a serious problem. I really think that keeping a high degree of suspicion is very important, because if you don't suspect, when the patient gets unstable, had a pain on his back, on his shoulder, whatever, you don't think about bleeding, you may diagnose it too late. So keep an high degree of suspicion. In doubt, make an angio. It's okay, it's fine, you wasted contrast, but you're much more relaxed from then on. And I strongly suggest you to, because these are procedures that we don't do that much, and ideally we should not do at all, we need to have the key on the shelf, and I really consider, think we should have material organized by procedure. So rupture of the aortic, what you need? You need this size of introducer, this size of balloon, this size of stent. What you need for an iliac? You need this introducer, that's balloon, that's stent. I think it makes it much easier because it's not a procedure that we do very often. Makes it more easier on an emergent situation for everyone to be on the same page, the technician, you, all the team. And basically that's it. Thank you.
Thank you, Enrique. It was the perfect wrap up for our session. We have only 5 minutes for a discussion, a quick discussion. I would like to ask Dr. Alberto Rodrigues any further comments on these last presentations.
Another thing we've been talking about vascular complication. Yesterday night on an excellent session, we've seen the discussion about cardiac surgery and interventional surgery. Don't forget vascular surgery or a surgeon experienced with vascular access. We sometimes have a vascular team in our hospital. There are some cases in which we call the vascular surgeon to watch with us the CT scan and help us to decide what best to do. And in some cases, they also come to the room and do the case with us. So this is a larger team, and the complications are really important, and we must know how to avoid them, and if they happen, how to solve them. Thanks for your presentations, and thank you for my comments.
Thank you, Dr. Albert. Bruno, any further comments?
Okay. Yes, very quickly. Once again, congratulations. I think the meeting and the cases were very good, and congratulations for the presenters. I just want to stress that doing structural intervention, I think you need a very strong expertise, and you need a very good practice in peripheral management of disease, and that can be something you can add in a curriculum or in a minimum expertise when you start to do TAVI or valvular procedures. Thank you.
Thank you, Bruno. Pedro?
Just a very short comment. We saw 6 cases of very wonderful cases, complications, and in all of those cases it wasn't need for emergent cardiac surgery. Most of them were solved percutaneously, and some of them we need vascular surgery to deal with the complication on vascular access. From my experience, I had several complications: coronary occlusions, aortic dissection, aortic perforation, complications in primary access, both occlusion and bleeding. And most of those cases we are able, if trained, to deal with those complications and treat them percutaneously.
Thank you. Professor Lino, any further comment?
I would like to stress and underline the conclusions of Enrique. We should plan the case, and that is the most important issue. And we should have near, and we should study the aorta, the iliac, all the dimensions, and we have before the intervention we should have the stents and all the material for if we have an emergency we can go very quickly to the complications.
A very thorough pre-planned procedure.
This is the most important comment that I think that we should have.
So you saved me work because that's the real take-home message, and I appreciate it.
And I'd like to say, we're doing this all together. So any doubt, any questions, seek help, discuss the patient. The pre-planning is just not us seeing the things, it's discussing things. That makes an insight, the better insight and the best results.
Thank you, Tiago. So I think it's time for us to close this very good session. It was a really very perfect opportunity for learning and
you for watching.
sharing experience. Thank you for all the presenters, those that are at home and those that are here. And we'll see each other next time. Thank you.
Till the next section.